Hello and welcome back to 90 Day Dental Day 36. Continuing with the perio theme, part 4 today, non-surgical treatment with Ian Dunn. Take it away.
Hi everybody, welcome back to the perio series of lectures. Huge thank you again to Ahmed for sorting this out and putting all this work and effort in. Today we've got to get through non-surgical treatment in about 10 minutes. So that's going to be a bit of a challenge, but I'm going to give you a quick overview, and it makes a few assumptions. It makes the assumption that we have optimized the patient's oral hygiene, so the patients are making considerably better efforts, and we've managed as many of the controllable risk factors as we can. What we're going to talk about today is what we physically do to patients when we get into the treatment phase of the perio journey. So, when patients join your practice, patients with periodontitis, they walk in and they effectively have a contaminated root surface. And it's a contaminated root surface that's not compatible or conducive with health. It will have cementum, it will have calculus, and it will have biofilm on it. And we know that the disease etiology is based on a biofilm maturing. As the biofilm matures, it produces more endotoxin. The body responds with an inflammatory response that is ineffective at dealing with the biofilm, and the inflammatory response is responsible for about 85% of the damage that we see in periodontitis. And so the concept of mechanical removal of biofilm being the cornerstone of periodontal therapy is well seated in modern periodontal management. And that mechanical biofilm can be removed removal can be done by the patient, but it can also be done by us as clinicians. And we can do that with an array of different instruments, hand scalers, ultrasonics, these modern air polishing systems. All of those things are very effective at removing and reducing biofilm. It's been interesting to read the literature over the last probably 20 years or more that have cast doubt on the importance of calculus. Now, nobody would teach the deliberate leaving of calculus deposits, but if we look at the statement that came out of this textbook, I'd encourage you all to have a look at this textbook. The first chapter in particular was particularly brilliant by Philip Preshaw, who was the professor of perio up at Newcastle for many years. He said that calculus does not cause disease, but he did go on to say that it is plaque retentive. And there is no doubt that the three-dimensional shape of calculus can harbour biofilm, and that can prevent tissues from healing. But calculus on its own does not cause disease. There are 3 good reasons why we look to remove calculus. The first one, it's a barrier to effective biofilm control, both for you and for the patient. And so we look to remove as much of the hard deposits above and below the gum line as possible. It looks rubbish, it's aesthetically displeasing, and it's a really good reason not to leave it there. And ultimately, it is way too much fun to leave behind, and I can't wait to get back to practice to start dealing with the calculus that will have developed over the last few months. But ultimately, and all joking aside, the barrier to biofilm control for you and for the patient is the primary reason for removing as much calculus as possible. But we know very clearly from the studies that even when we try, we don't get every last bit. We've got multiple ways of producing this decontaminated surface. Like I say, we can do hand instrumentation, we can do ultrasonics, we can do combinations of the two. I think what everybody agrees with now is that root planing is quite an outdated technique, and even with hand instrumentation now we can choose to be more conservative with the root surface, because planing was the deliberate and intentional removal of part of the tooth substance, the cementum. And we see patients who've had a lifetime of periodontal management with quite significant iatrogenic damage from these older techniques. And hopefully most of us will agree that we're moving towards the concept of, or have moved towards the concept of debridement, where we are removing the plaque and or calculus, but not intentionally removing tooth substance. So again, we can do this potentially with an array of different instruments, but we've got to be careful that we're not planing and that we are being as conservative as possible, but leaving the patient with a surface that is conducive to healing and health. Multiple studies have looked at this, and so some people believe that hand instrumentation is better than ultrasonics. Some people say ultrasonics are better than hand instrumentation. Other people like a combination of the two things. The studies are clear that there is no one technique that is superior to the other, and really this is very much about what you do and what works for you in your practice. This study just looked at the clinical skill, time and stamina, and it said that the ultrasonic is probably the universal tool because it meets the same clinical outcomes but with a reduced skill set or time commitment. Philip Preshaw said it in his book. He said ultrasonic instruments are indicated to debride the surface. It is gentler, it's less destructive, and it achieves the same clinical outcomes but without causing tissue damage. And then he commented on the time efficiency as well. Just to put this into context, there are studies that have looked at this. This is more than just an opinion. We've got a number of studies that have looked at the most treatment versus the least treatments. And the only one that I'm going to mention very briefly is this study that looked at severe periodontitis patients. The control group had 4 hours of traditional root planing, and the test group had 1 hour of ultrasonic debridement. In a second phase of treatment at 3 months, the root planing group were re-root planed if there were deep pockets, and the ultrasonic group were re-ultrasonic if there were any deep pockets. Then they closed the study. And what's important to see from this study is that despite the significantly different approaches and time commitments, there were no clinically or statistically significant differences between the treatment outcomes for the two groups. So you're getting similar treatment outcomes for significantly less time. So we've got an efficient treatment modality for managing the root surface. Again, if hand instrumentation works in your hands, then absolutely, by all means, carry on doing it. And ultimately, in this post-COVID era, as we go back to practice, depending on how we are fixed with using aerosol generating instruments, it might be that many of us are having to hand scale where we previously would have ultrasonic, but only time will tell where we will go with that. Again, leaving with Philip Preshaw at one of the final words on this, he said that root planing can't be justified as a concept. He said, to put it more simply, it is not possible to remove all the calculus. I said to you already that countless studies have shown that we do not remove all the calculus even if we try. He then went on to say that we do not wish to remove the cementum. And again, we've got multiple studies that go back as far as the 80s that show that the endotoxin is superficially located on the cementum and that about 99+% is removed through less aggressive treatments. Only about 0.25% of the endotoxin is actually inside the cementum. And then his summing up was, therefore, root planing does not have a place in modern periodontal therapy. I think he is very much referring to the old-fashioned, very aggressive management of root surfaces. And so if we can be more conservative with hand or ultrasonics, then Philip here is suggesting that we can achieve similar clinical outcomes. Ultimately, we need to buy into the fact that periotherapy is incredibly effective. Tooth loss in well-treated, well-maintained periodontal patients is very low, and we are very successful at saving dentitions with this non-surgical approach. And it really forms about 90% or more of my specialist practice. We manage most of our cases without surgical intervention. Surgery very much still has its place. I look forward to listening to Hatham's lecture where he will be, I'm sure, talking about pocket reduction and periodontal regeneration, and they very much have a place, and we do those things in practice. But the majority of patients are managed non-surgically, and that should be the case in your clinic. And what we see with these patients is they just get better and better, and the stability becomes a given if the patients buy into their plaque control and if ultimately we do our non-surgical therapy well. There should be relatively little need for adjunctive therapies. This systematic review looked at a number of different locally placed medicaments, and the study is very clear that the gains that we see when we use these local antimicrobial agents in conjunction with treatments produce minimal clinical benefit. So there is a subtle clinical benefit, but it's minimal, and I've got to be honest, I don't really use local delivery products. There is some good evidence for the use of systemic antimicrobials. I think the general rule of thumb with this is that it should be incredibly rare cases, such as old-fashioned aggressive periodontitis, and we occasionally consider it in severe and progressing forms of periodontitis. But again, it's a controversial topic that we can't do justice here, and in general practice, you are unlikely to be thinking about systemic antimicrobial therapy for your periodontal patients. Ultimately, perio boils down to this. Patients walk in with deep bleeding pockets, they have accessible biofilm and they have inaccessible biofilm. We get the patients to take responsibility for the top bit, we can then take responsibility for the bits they can't get, And as we do that, we get a resolution of inflammation. The pockets will shrink. We know that 70% of the pocket reduction in deep pockets is due to recession. And we get patients who then have pockets that are manageable, where they can self-maintain together with a little bit of support from their dentist, hygienist or therapist. That really is periodontics in a nutshell. In summary, and we'll keep this very quick, we need to optimize patients' oral hygiene to get successful non-surgical outcomes. We need to control as many of the manageable risk factors as possible. We need to decontaminate the root surface in a thorough and conservative manner, and hand instrumentation can do that, as can ultrasonics. And the studies show that they do similar clinical outcomes in a shorter period of time. Again, we may or may not be able to rush back to our ultrasonic scalers. Always, with all treatment, monitor and review the outcomes and make onward treatment decisions. Hopefully that's been of some use. I've really enjoyed being part of this series. I look forward to catching up with the rest of the perio section and the lectures that are coming in the next few weeks. Thanks for listening, and thank you again to Ahmed for organising this series. Take care, guys.
Thank you, Ian, for another cracking session. And tomorrow we continue perio with the next part on surgical treatment. Till next time, and just as a quick reminder, please do follow and like us on both Instagram and YouTube to keep promoting and supporting these videos. Please do comment and give us the support that we need to continue making them right to the end of the series. It's always nice to get the appreciation. See you tomorrow.